This evening, I'm going to speak to you about advances of speech pathology management in the severely burned patient. So a little bit left of field for speech pathology specifically. Okay, first of all, I've got no financial disclosures to mention. I do have consent for all the patient images and videos that will be presented within this slideshow today for research and educational purposes, but I do ask if you could please not take any photos of patient slides. Also, just a quick note as well, I'm sure this won't be of any surprise to you, but there are some graphic images within this presentation, so just a word of warning. Okay, so I wasn't quite sure about what people's experience would be with regard to severe burn injury, so I thought I'd give a little bit of background to start off with. So severe burn injury may occur as a result of exposure to thermal stimuli, whether it's cold or reverse thermal, which is reverse thermal, or heat in the case of fire or scald or contact, as well as chemical, whether it might be acid or alkaline, electrical, as well as friction injuries. And I'll show you some examples of those in the slides just to come now. So this is an example of thermal burn injury. So on the left-hand side, we had a lady here who fell asleep with a cigarette and her mattress caught alight. So you can see the sort of the deep charred appearance of her burn injury, especially involving her scalp and her upper torso. Whereas on the right-hand side, we have a young gentleman where he sustained his burn as a result of flammable liquid and flame. And we can see down his left arm that he has some escharotomies to relieve the underlying pressure, as this was a full thickness injury. And I'll talk a little bit about how we describe severity of burn injury in a couple of slides to come. We have chemical burn injury here on your left-hand side of your screen. This is a work-related injury where a gentleman was kneeling, working with concrete. So this is lime burns. On the right-hand side, we have an intraoral burn, which is obviously something that I'd get a lot more involved with. This was a gentleman who went up in the middle of the night to get a drink, and he was unaware that his flatmate had been cleaning, and there was a glass of liquid on the sink just next to in the kitchen, and he thought it was water and took a mouthful. Fortunately, spat it out straight away, but it had some caustic agent in there. We also see electrical burn injury. This is one of my patients from a few years ago that we published a case study on. Of all professions, he was a retired electrician. He was helping a friend move a fridge. And what do you do when you've got too many wires and you don't have enough hands to hold everything? He held it between his teeth, but unfortunately, he was wearing a metallic partial denture and the wire was still live. So that conducted the electrical current and he resulted with an electrical burn injury. And lastly, we have a friction burn injury. Obviously, this is not a type of patient that I would see particularly often, but this is a very classic case of a friction burn injury in the event of a hand getting stuck with a conveyor belt. Okay, so I thought we'd also back up a little bit and we talk about the major functions of the skin, because the 7 major functions of the skin are affected not only in the first instance of sustaining a burn injury, but also long-term as well. So the skin plays a very important part that can be disrupted during a burn. So first of all, temperature regulation is a very, very important component of cutaneous tissue. It allows us to be able to feel hot and cold. And if we are missing that superficial layer of skin, it can be really, really quite challenging to manage and regulate our body temperature. The skin's also our sensory interface, the way we interact with our environment, that we can actually feel textures, whether something's soft, whether it's smooth, whether it's rough, and also whether it's sharp. It also plays a role in immune defense as well. So it is our barrier against bacteria and infection. So similarly, it prevents, it's our barrier against a bacterial invasion. It also controls our fluids within our body as well and manages our fluid loss. It also plays a major role with metabolic function as well. And lastly, it's our interface with our social environment. It is our personality. It's the way people recognize us. So it's really, really quite critical in terms of its psychosocial aspect of interacting with our environment and also with our social counterparts. If we look at how to classify a burn severity, there is a couple of main things that we really look at. So first of all, we look at the severity of a burn injury defined in terms of the depth of the burn injury. Now, we can describe a burn, whether it might be superficial, dermal, or deep/full thickness, and that talks about how deep that burn actually penetrates through the cutaneous tissue. Second of all, we look at the extent of the burn injury. So this is the total percent body surface area that the burn extends over the body. Now on the right-hand side, I've got an illustration here of the rule of nines. Now this is just a very, very simple way to be able to calculate burn surface area. There is also more sophisticated ways. This is a very, very quick way to be able to calculate how big a burn is, and it allows us to be able to calculate not only the severity of the burn, but also fluid resuscitation requirements. But also, and you'll see here on our second point, we also look at what's called a box score. A box score gives us an idea of the risk of mortality as a result of sustaining a severe burn injury. We look at the total body surface area burnt, we add it to the patient's age, and if it's over 100, the risk of that patient succumbing to their injuries increases significantly. Another point that's more interesting to consider, and particularly relevant for the speech pathologists as well as all our ENT colleagues as well who might be online, that our risk of mortality also significantly increases with the presence of an inhalational injury. And I'm going to go into that in a little bit more detail during this presentation. Okay, so what are some of our complications of severe burn injury? Now, this is an image from our intensive care unit. This is one of my patients. Clearly, they're hypothermic. One of those mechanisms of the cutaneous tissue. Obviously, these patients have trouble regulating their body temperature. So our immediate complications of severe burn injury not only can be life-threatening, particularly in impending airway compromise, but we also have systemic injuries or considerations as well, which I'll talk about in the next slide. Our short-term complications, we have not only ongoing systemic issues in terms of those sort of beyond that sort of initial 24 to 48 hours within that first week. There's the physiological trauma that the patient has sustained, as well as the acute deconditioning, particularly if they are critically unwell and needing to be managed in the intensive care environment. We also need to manage the pain, the psychological trauma of going through such a traumatic event. There's also the scar tissue and the contraction development that we need to manage in that acute phase as well. When we look at more longer term, we still tend to have those issues with scar tissue, contracture management to take care of, but also we're really now looking at the functional implications, and we see big issues with pain and itch. And some of my occupational physiotherapy colleagues, specifically up in Brisbane, have done a lot of work in this field. Not only once the patient is able to leave hospital, then there's that real psychological adjustment to be able to really reintegrate it into the community and how they can actually adapt and manage within their social circle, within their family, and also, of course, in the workplace environment as well. Okay, a little bit more about that systemic effects that I mentioned earlier. Firstly, we need to really consider what the importance is of timely first aid and resuscitation. So as simple as it is, 20 minutes of cool running water can mean the difference between often life and death in these patients. These patients experience a widespread systemic response. They have extreme fluid shifts, and this is where the airway can be significantly compromised, even in the event of a patient not sustaining an inhalational injury. Should they sustain a burn to the head and neck region, and they might have a burn that might be circumferential around the neck, those fluid shifts can result in airway compromise. So it's really important that we do manage that in the first instance. The burn patient's body undergoes a multi-organ response. We do see massive issues, particularly in terms of kidney function. And so it's really, really important that this is very, very closely monitored and managed in the intensive care environment. Also of interest is the hypermetabolic response for our patients as well. These patients, from sustaining such a massive insult to their cutaneous tissue, result in a catabolic state, which you have severely inflated heart rate, often blood pressure as well, but their metabolic rate is far exceeding what it would be normally. And to give you a general idea, in a patient who sustained a burn to 20% of their body, their nutritional requirements are often about 150 to 200% of what it would normally be. So if you imagine what you eat on a normal daily basis, and you have this significant burn injury, the ability to be able to consume enough nutrition to be able to heal your burn wounds and to be able to participate in rehab, it's really quite tricky. So this is why enteral feeding is very highly recommended and implemented in this cohort. And we don't often, we see that this catabolic state is not just in that critical care environment, it's quite prolonged, certainly past the acute phase and well into the rehabilitative phase. Now, if we look at what the role is of speech pathology and burns, obviously we have a role in the assessment and treatment of swallowing disorders as well as communication disorders, specifically looking at voice, speech, and language in the terms of facial expression when we have burns to the head and neck region, if we have scar tissue across the facial area, which is really important for conveying the suprasegmental aspects of communication, our emotion, that can be compromised. And our assessment and treatment extends across not only the intensive care environment, but as well as their admission within the burns unit in that inpatient and outpatient rehabilitation period. So literature is becoming increasingly available over the past 10 years, 10 to 15 years specifically, and we have predictive factors for both dysphagia and dysphonia in the adult burn patient. Burn injury to the head and neck region, inhalation, the presence of inhalational burn injury, the presence of intubation and mechanical ventilation, tracheostomy, if they have a burn greater than 18% total body surface area burn, if their age is beyond 75 years, regardless of the location of burn, and if they have an associated neurological injury, all these things play a part and increase the risk of dysphagia and dysphonia in these patients. And lastly, of course, the presence of significant comorbidities, similar to any sort of patient, increases the risk of these other issues which relate to voice and swallow function. So we look at the incidence of swallowing disorders following thermal burn injury in the general adult burn population. My close colleague Anna Rummuck published this paper in 2011 and has explained that the incidence of dysphagia in this general burn population to be just above 11%. If we look at those patients who are beyond 75 years, regardless of the location of burns, this incidence increases to almost 47%. But if we have a patient, regardless of their age, who has an inhalational burn injury, the incidence of swallowing disorders is extremely high, at just under 90%. We do also have some preliminary data regarding the incidence of voice disorders in inhalational burn injury, and this sits around about just under 75%. But interestingly, and I'll speak to this a little bit more in a few slides to come, persistent laryngeal pathology is often evident at 6 months post-inhalational burn injury, given the fact that we obviously know that the larynx is an incredibly fragile structure, and any sort of insult to the larynx can have significant sequelae. So what are the causes for dysphagia? It's often multifactorial with sensory and motor components, and this can be as a result of direct impact of the burn on the oropharyngeal and laryngeal tissue, as well as being from acute deconditioning, muscle atrophy as a result of their critical care stay. Cause for voice disorders is often also multifactorial, and this again can be because of laryngeal tissue trauma, either from the inhalational injury themselves, and then can be exacerbated by the presence of the ET tube, But we often also see voice disorders as a result of maladaptive compensatory vocal behaviours. We can see psychological voice disorders, and again, in the presence of acute deconditioning and muscle atrophy, we can see voice issues as well. The type of clinical presentation we see of swallowing disorders in this cohort is really characteristic of critical illness polyneuropathy or ICU-acquired weakness, but it's really significantly amplified both in the motor as well as the sensory component. And we're postulating this might potentially be as a result of the catabolic process that these patients are sustaining. Swallowing disorder presentation may also be further complicated if inhalational injury is present. And interestingly, if we talk about the histology, as you would well know from your ENT experience, the majority of the oral cavity is curiously resistant to scar tissue. Not only the tongue, the buccal mucosa, the hard and soft palate, as well as the posterior pharyngeal wall, but the floor of mouth is different. And this is important to consider when we're thinking about ingestion injuries. Now, thinking of ingestion injuries, this is really in our patients that may have sustained any sort of injury as a result of ingestion, whether it's hot liquid or whether it's some sort of chemical, that often we see this, the chemical or the fluid seep to the floor of mouth, and we can see issues with tethering, certainly in the floor of mouth region underneath the tongue. Okay, a quick refresher for those who don't often look at video fluoroscopy, just to get you reoriented. So this is what a normal patient looks like on video fluoroscopy. Hopefully my videos are playing nice and clearly for you on the other end there. As you can see, the swallowing process is really quite efficient, very, very quick. This patient has got intact swallowing function and is swallowing a normal fluid bolus. As opposed to a burn patient here, as you can see here, this image, the presence of the nasogastric tube, it looks like a very large or wide bore tube, but in fact, it actually is a fine bore. It just looks enormous in this patient. But you can see just how much this patient is struggling with transporting the contrast material from the oral cavity through to the esophagus. You can really see that reduced base of tongue strength, the reduced propulsion of the bolus through the pharynx, and as a result, you're getting significant retention at the level of the base of tongue and vallecula. You've also got impaired higher laryngeal movement with impaired airway closure at the height of the swallow, which is resulting in penetration of material. You can see it seeping down the posterior aspect of the epiglottis down towards the airway. Okay, another image that should be incredibly familiar to you guys. So in the burn patient, where we really see this weakness is at the level of the base of tongue, as well as the pharyngeal constrictors. But further to that, we often see it in the musculature that's responsible for airway closure at the height of the swallow. So these are the three areas that we're really quite concerned about, and certainly even more concerned about than your general ICU-acquired weakness patient or critical illness polyneuropathy. So we have that weakness at the level of the base of tongue. We often get retention in the vallecula. If we have significant weakness at the base of tongue and retention at the vallecula and poor airway closure, we have penetrant material extending into the laryngeal vestibule. Similarly, with the pharyngeal constrictors, if they are not working efficiently, we have retention within the piriform fossa, which similarly post-swallow, if they're unable to be cleared, will also overflow often via the posterior cricoid region into the laryngeal vestibule. Okay, so this gives you, this is a FEES of one of my burns patients. Clearly you can see his nasogastric tube in situ here. Now I do apologize for the clarity of the images. It's with one of our old fiber scopes. You can clearly see this gentleman has a left chord palsy, but he has impaired pharyngeal clearance as well as airway closure at the height of the swallow, and you've got significant retention of fluid material as well as salivary secretions, not only throughout the entire pharynx, mainly more in the piriforms than in the vallecula in this instance, but also within the laryngeal vestibule as well. It's quite a messy, messy swallow. So what do we do about managing these patients? Swallowing rehab should be commenced as soon as possible in the intensive care environment, generally within 24 hours post-extubation or of insertion of tracheostomy. Improvement can be slow initially, but most achieve pre-morbid diet by the time of discharge, which is really reassuring. In this specific cohort, these is preferred for video fluoroscopy or over video fluoroscopy, obviously for the laryngeal and logistical reasons. We use a lot of education, compensatory and therapeutic strategies, and we also try to minimize the risk for orofacial and laryngeal or laryngopharyngeal contractures at the same time. Burns patients are often quite young, they're cognitively intact, which makes them fabulous candidates for dysphagia rehabilitation. And we apply the usual principles of neuroplasticity in relation to swallowing musculature. And with our focus on swallow rehabilitation, we really look at strengthening the base of tongue, the submental, pharyngeal and pulmonary musculature, and also focus on increasing the range of movement, not only of the laryngeal musculature, but also orofacial musculature as well. This is this same patient that we saw just earlier, following rehabilitation, specifically targeting the tongue base, the lower pharynx, as well as airway closure. You can still see he's got that left quad palsy, which at this point in time, I think we had confirmed it was a paralysis. But you can see he's got much better base of tongue to posterior pharyngeal wall approximation. It's not perfect, but he's certainly getting much, much better clearance. And he's also maintaining airway closure during the height of the swallow, resulting in no penetration or aspiration. He's just taking a small amount of solids here. This is some diced fruit. So you can see here that it's not perfect just yet. We had continued rehab following this phase, but his clearance is certainly much improved than the initial phase. In the interest of time, I'm going to keep going. Okay, just going to touch quickly on voice disorders following burn injury. So the clinical presentation again is very characteristic of critical illness polyneuropathy as well as long-term intubation. We see localized laryngeal trauma potentially exacerbated by the presence of an inhalational burn injury. We often see quite a rough and breathy vocal quality with incomplete glottic closure at the posterior aspect of the larynx. Sometimes we see a strained vocal quality due to maladaptive voicing patterns as these patients can sometimes develop secondary muscle tension dysphonia. Long-term dysphonia beyond 6 months is also not that uncommon in this population, especially in the context of laryngeal scar tissue as well. There's a few images of some of my inhalational burn injury patients. On the left-hand side, this is an accidental steam inhalation. On the right-hand side, this was an accidental ingestion aspiration of a flammable substance along with flame. On the far right-hand side, that's her main carina. So just very quickly, a little bit more about inhalational injury and laryngeal contractures. We confirm the presence of inhalational injury either by laryngoscopy or bronchoscopy. It's very difficult to describe and quantify the depth or the severity of an inhalational burn injury. So generally it's classified as a supraglottic or a subglottic injury. The histology of the laryngeal mucosa increases the predisposition to scar development and contracture. And specifically, we see this in the posterior cricoid, the posterior glottic area, as well as the areoepiglottic folds. So we see shortening of those areoepiglottic folds. Just a reference slide on your left-hand side of a normal healthy larynx on the right-hand side. So what we tend to see in those patients with inhalational burn injury and laryngeal contractures, we see the arytenoids drawing together and we see the areoepiglottic folds shortening. And that's why we end up with those patients who tend to have a sort of a very low pitched because they can't lengthen the vocal cords, but we get that rough quality because their cords are closer together, but they are splintered just a small amount apart at the posterior aspect of the glottis. That's how we get that sort of rough, breathy vocal quality with that sort of poor pitch range. Just to give you a little bit of an idea of what some of this can actually look like. So on the left-hand side here, we have a milder inhalational burn injury. We do have a little bit of tension in the posterior cricoid region, as well as shortening of the areoepiglottic folds. Okay. Whereas on the left-hand side, this is a much more significant injury. And my lady here, this is the one who had pointed out the inhalational burn injury at the level of the main carina. She sustained a significant inhalational burn injury, and this is her trying to do a deep inspiration and a gentle M sound. You can see just how much range she has lost in her larynx, and this is despite rehabilitation. Okay, a couple of microlaryngoscopy images. So in a severe case, we can see tethering between the true and the false vocal cords, but we haven't seen this for quite some time because we employ a lot of prophylactic laryngeal contraction management, which I'm just going to talk about in this slide now. So again, similar to swallowing management, we try to commence our voice rehabilitation as soon as possible in the intensive care environment. If the patient is tracheostomized, we apply a speaking valve, whether it's in line with the ventilator or not. We employ regular laryngeal and pulmonary toileting to try to assist in the debridement and clearance of that non-viable tissue. And we really educate our patients really early to try and prevent any maladaptive voicing behaviour taking place. Early nasendoscopy and stroboscopy obviously is tools that we regularly employ to evaluate those patients who might potentially be at risk for laryngeal pathology, and we use PPI prophylactically for all of our patients. Steroids is an interesting thing. It really weigh up the risks and the benefits of using steroids. Certainly for our cutaneous skin graft, steroids have been shown to be unhelpful in getting those grafts to take. But certainly if we have significant issues with the airway, that will take precedence, and we will use those steroids. We also employ preventative treatment for our laryngeal contractures as well. So our rehabilitation, same principles for contraction management for cutaneous issues. Scar tissue tends to develop during the healing phase where collagen reformation is irregular, and we get that sort of lumpy type appearance, and then it contracts into a position of comfort. So for a larynx, that would contract into a position where it draws the arytenoids together and also shortens the areoepiglottic fold. So what we really focus on trying to do is range the larynx as much as we possibly can. Certainly abducting the vocal folds and then gentle abduction, but we also try to lengthen the folds as well to try and stretch not only the true vocal folds, but also the areoepiglottic folds as well. So just to summarise and draw this one to a close, because I'm very conscious of time, swallowing and voice disorders are certainly very common in the patient with severe burn injury. Predictive factors have been identified and validated, and they are encouraged to be used across all burns units to identify those patients who might be at risk. In those patients with inhalational injury are 8 times greater risk for swallowing disorders than the general burn patient, and 16 times greater for those without an inhalational component to their burn injury. It's reassuring that swallowing disorders often prove first or prior to voice recovery, with a good prognosis for complete recovery by the time of discharge from the acute care environment. That voice disorders can persist past 6 months and often can be permanent. So early assessment and treatment to minimise the severity and the functional implications of these disorders is really quite paramount. There's lots of work ongoing in progress where we're looking at validating the incidence and risk factors for swallowing disorders in the older burn patient, as well as gathering further data on voice outcomes, incidence and predictive factors following inhalational burn injury. We're also currently running a clinical trial to determine the feasibility of a strength-based dysphagia treatment protocol for those patients with ICU-acquired weakness, including a severe burn injury cohort. And lastly, we also want to look at what voice disorders are in the general burn population. Thank you very much for your attention. This is an image of the hospital that we work at, and with a lovely view up Sydney Harbour. The burns unit is located up top. But I will thank you very much for your attention. I'll be very pleased to take any questions.